Okay, well, welcome to today's pediatric teaching. I wanted to talk today about emergencies in pediatric oncology, and we've had some teaching before about oncology in general, and some of you will also have been to teaching sessions with Dr. Gwenda Anger or Dr. Benjamin Dow, who've been teaching about pediatric oncology. But today I wanted to focus on just a few emergencies in pediatric oncology. And while it's true to say that there are almost all um, the identification and management of children, regardless of what their cancer is an urgent matter. And so we need to be good at, for example, the basic things of identification of the pale child, or the differential diagnosis of a an abdominal mass, for example, in a child, or the early warning signs of retinoblastoma, or distinguishing the child who has a brain tumor from a child who's got some other form of encephalopathy like a tuberculoma. Those are more basic skills, I guess, in pediatrics that we need to master in pediatric oncology. But there are also some specific emergencies that are quite common when you look after children with cancer, and they'll be faced by people who are working in tertiary centres and also in provincial level hospitals. These are the five that we'll talk about today. Firstly, the condition of hyperleukocytosis, and many children with leukemia they present with leukocytosis. They've got a high white cell count, but there's a small section of children, a small proportion of children who have leukemia that have a very high white cell count when they present, and that poses some specific problems, and it requires an emergency response. A second is tumor lysis syndrome, which anyone treating childhood leukemia or lymphoma may be exposed to. The third is the child who's got a mediastinal mass, and we'll go through the differential diagnosis of a mediastinal mass. The fourth is a child with febrile neutropenia. So they've had chemotherapy and they've got neutropenia, and then they develop sepsis, febrile neutropenia. And this is something that's very common, and again is a pediatric oncology emergency. And the fifth one is that of coagulopathy. So, firstly, hyperleukocytosis. Well, as I said, all children with leukemia, no, not all children, some children with leukemia have a low white cell count. They may have a marrow aplasia, but more often they have a high white cell count, but very high white cell counts, more than 100,000 per millimeter cubed, or more than 100 times 10 to the 9 per liter. There's two ways laboratories report such data, but if you understand the normal white cell count is 4 to 15, depending on the age of the patient, 4 to 15. But in patients that have more than 100 per times 10 to the 9 per liter, they have hyperleukocytosis. And it's particularly a problem. Hyperleukocytosis is particularly a problem in acute myeloid leukemia. It's less of a problem in ALL, but if you've got more than 200 or 300,000 white cells in acute lymphoblastic leukemia, then that is the problems are rather similar. In AML, the myeloblasts, the cancer cells are larger, and the coagulopathy is more severe. So those children are more at risk of hyperleukocytosis and the clinical syndrome of hyperleukocytosis at lower levels, such as 100,000. Whereas children with ALL, they typically become at risk when their white cell count is 200 or 300,000 per millimeter cubed. And the children who've got hyperleukocytosis are at risk of some serious complications, and these can occur at the time of presentation, or they can occur in the first 24 or 48 hours, or after treatment has started. And they're ischemic or hemorrhagic strokes, and I'll explain why that is. Sometimes thromboses, particularly in the lungs, pulmonary thrombosis, lung clots in their lung, and pulmonary infarction, and tumor lysis syndrome. We'll go through a few of those and explain why these children that have hyperleukocytosis are at risk of these complications. The main reason is that when you've got a very high white cell count, especially with myeloblasts, the large myeloblasts, then you have hyperviscosity. The blood is thicker. It's thicker because of the very high white cells. There's also the white cells, the leukemic blast cells produce lots of cytokines that cause inflammation. And if you've got, as you understand, if your neutrophil count is high, even if it's 20 or 25, then those neutrophils are active and they're producing inflammatory mediators and they cause inflammation. But when you've got a very extremely high white cell count of more than 100,000 with AML, particularly, then those myelocytes are producing lots of inflammatory mediators. So you've got a hyperinflammation, hyperviscosity, and also because of the viscosity, the thickness of the blood, then you have hypercoagulability. It's quite likely that the blood will clot because of the density of the white cells. And because of all of that, especially the hyperviscosity, the child may have reduced cerebral blood flow. So they're at risk of ischemic strokes. And because of the hypercoagulability, those children are at risk of both ischemic strokes but also hemorrhagic strokes. So I'll explain the hemorrhagic stroke, the reason for that, in a moment. There are some warning signs for such children, and I always think that if you've got a child who's got new diagnosis of ALL or AML and they've got a high white cell count that's approaching 100,000 and they develop severe headache or vomiting, or they have any signs of neurological deterioration, or they've got a low oxygen saturation, then you should really be thinking about, have they got hyperviscosity syndrome, hyperleukocytosis, and is that causing impairment of their cerebral blood flow? Are they at risk of strokes? Are they at risk of pulmonary thrombosis, etc.? If possible, if you have access to it, then do a CT scan. It's not always possible, of course, but on a CT scan, you're looking for edema or ischemia, cerebral edema, or ischemia or bleeding. They're the three things you're looking for on a head CT scan. If you did see those things, it's important to provide neurological protection. But I think we probably can, even if you don't have access to a CT scan, and even if you aren't able to provide a neuro-intensive care, there's some things that you can do that will help, including the neuroprotective measures we've talked about before, having the patient 30 degrees, nursing the patient 30 degrees head up, giving avoiding overhydration, those sorts of things. We talked about neuroprotection before. These patients often have a coagulopathy, and they often have thrombocytopenia, as well as a low platelet count, as well as a high white cell count in the peripheral blood. And they have thrombocytopenia just because their marrow is packed, bone marrow is packed with leukemic cells. You should, in these patients, check the full blood count and the coagulation if you can. Do it daily until they're stable, especially if they've got thrombocytopenia. And I always try to keep the platelet count above 50,000 if there's any risk of hyperviscosity or cerebral injury, but don't keep it very high, because if you keep giving platelets, that can feed a clot if there is one. If there's any bleeding on the CT scan, then you need to urgently correct the coagulopathy and keep the platelet count above 100,000 if there's any bleeding on the CT scan. But you're providing the key aspect of management is to reduce the white cell count to a safe level as soon as possible. These are two patients that had hyperleukocytosis and ischemic strokes. Now, not all children, I've seen many children with hyperleukocytosis who don't have any cerebral events, cerebral abnormalities, so they won't all have that, but a small proportion will get a serious cerebral abnormality. And this is an ischemic stroke. You can see that occurs because of this hyperleukocytosis, hyperviscosity. And on the right-hand side is a hemorrhagic stroke, which occurs because of the hemorrhagic stroke being the whiteness, and the ischemia being edema, or ischemia being the blackness, the low attenuation compared with the very high attenuation of the of the hemorrhage. Hemorrhagic strokes occur because patients who have hyperleukocytosis and coagulopathy or hypercoagulable state, they end up consuming, having a consumptive coagulopathy. So they consume a lot of clotting factors, and then they're at risk of bleeding. So there are some aspects to the clotting that you need to keep in the normal range, especially the fibrinogen, and try to make sure that the INR is not too high. What you should try to do is have induction chemotherapy that's fairly prompt and will reduce the white cell count to a safer level, under 50,000, as virtually as quickly as you can. Those who've treated leukemia will know that often giving fluid hyperhydration to begin with lowers the white cell count. It almost always does that. And then when you add steroids on top of that, then the white cell count will often come back to quite a safe level. Sometimes after you start cytotoxic chemotherapy, that is like vincristine or adriamycin, the sorts of treatment for ALL, for example, then sometimes the respiratory and neurological status may actually worsen. And that's usually because of when the cytotoxic chemotherapy is causing a lysis, a killing of those malignant cells, then they release inflammatory mediators and procoagulants are released from those dying malignant cells. And so all children during their early treatment, in the first week of treatment, need close observation in the intensive care unit. They shouldn't just be given chemotherapy, of course, and put down the back of the ward, or when they come in with leukemia, they should be, that's a serious enough problem, especially if they have hyperleukocytosis or they have some other risk for deterioration. They should be in the intensive care area of the ward. I wanted to cover tumor lysis syndrome now, and many of you will have seen this or heard about this, but it's simply that when you give chemotherapy, especially cytotoxic chemotherapy, then you get lysis of cells. Sometimes you get it even when you start with steroids. The earliest phase can lead to the earliest phase of treatment, even starting steroids, can lead to a rapid lysis of malignant cells, and what then happens is that there's a release of all the chemicals that are inside the cells, and they increase. So cells are rich in phosphate and they're rich in potassium, and they've got lots of DNA inside the nucleus of the cell. And it's the breakdown of all of those, the breakdown of the DNA, that leads to high levels of uric acid, and the phosphate and the potassium get released, and you get patients develop hyperphosphatemia, high levels of serum phosphate and high levels of serum potassium. And that can lead to a metabolic acidosis and complications of hyperkalemia. And because of the very high phosphate, that will combine with the calcium that's in the blood and precipitate hypocalcemia. So the calcium and the phosphate that's in the blood combine, and they then get precipitated into blood vessels. So what's often called dystrophic calcification of blood vessels, or they get deposited into the kidneys. And because of that, although the phosphate will go up, often the serum calcium will go down. And sometimes you get this complication, which is tetany. This child has tetany related to hypocalcemia, and you can see the tetanic spasm in the child's wrist. So tetany is a problem, or seizures. Tetanic seizures are a problem, but also is that when you get a lot of uric acid released and calcium and phosphate deposited in the renal tubules and the glomerulus, then you get a kidney injury. And so the sorts of things that can happen when in severe tumor lysis syndrome are complications of hyperkalemia, including arrhythmias, the complications of low calcium levels in the blood, such as tetany, the complications of high uric acid in the blood, which is largely initially deposition in the kidneys, and if combined with the complication of calcium phosphate deposition in the in the kidneys that can lead to an acute kidney injury and can reduce renal function. And that's especially the case, for example, if a patient's exposed to other nephrotoxic agents. So we always need to be careful not to expose such children to other nephrotoxic agents, and we need to be very mindful of their kidney function when you're starting treatment for acute leukemia or acute lymphoma, especially where there's a lot of mass disease. Um, the 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 highest risk of tumor lysis syndrome is proportional to the number of malignant cells, and those sorts of cancers that have very high uh, numbers of malignant cells, such as lymphomas that have got a lot of mass disease. They've got a big mediastinal mass, they've got a big liver or a big spleen, lots of lymph nodes that are enlarged, or children who've got hyperleukocytosis, like acute leukemia, that have very, very high white cell counts. They're the most risk of tumor lysis syndrome. They'll almost certainly get tumor lysis syndrome or tumor lysis, and our job is to protect them from getting tumor lysis syndrome. That is the consequences of the tumor lysis that you hope and expect will happen when you give chemotherapy. And so the sorts of things that we can do, well, firstly, we can give hyperhydration with an isotonic solution. And probably the best sort of solution is Hartmann's solution or normal saline, or there's another IV fluid called Plasmolite, which is not usually available. And you run it at 1.5 to 2 times maintenance. I'll explain how to do hyperhydration properly in a moment, because it's not just giving a child a lot of fluid. That's what people think it is, but it's not just that. The second thing is to use allopurinol, and allopurinol is a xanthine oxidase inhibitor. Xanthine oxidase is an enzyme that converts hypoxanthine to xanthine to uric acid, and so it inhibits that, so you don't get uric acid deposition in the kidneys, or not nearly as much. There is another medication called rasburicase, which is even more effective than allopurinol. And if you, it's more expensive, but when it is available, where it's available, we rarely see severe tumor lysis syndrome these days if a child gets rasburicase. But where allopurinol is available, it's still really important to be aware that tumor lysis syndrome can still occur, and we need to do all the other things. The key about hyperhydration is that it's not just giving a lot of fluid in, it's also ensuring that all that fluid that goes in comes out. And that uh, can be more of a problem, because we often think of that an adequate urine output is zero point 0.5 to 1 mils per kilo per hour of urine. That's the normal urine output. But actually, if you're giving 1.5 to 2 times the normal maintenance fluid intravenously, then and plus other fluids that a child might require because of the treatment for leukemia, or the treatment for chemotherapy induction for any other cancer, then they may require 4 to 6 mils of per kilo per hour of urine output. And sometimes that requires you using furosemide or mannitol to ensure that there's an adequate urine output. And so you need to assess the hydration regularly and try to ensure a neutral fluid balance in these patients. They shouldn't get overhydrated. Sometimes in the past, we've alkalinized the urine. That is, bring the urine pH up to 7 or 8 by adding sodium bicarbonate to the hyperhydration fluid. These days, I think it's well known that that may worsen calcium phosphate deposition, especially if you've got a high phosphate level. It's not such a good idea anymore to alkalinize the urine. So usually hyperhydration requires just an isotonic solution without potassium, ideally without potassium, and careful attention to fluid balance, so you get a neutral fluid balance. You should really avoid intravenous calcium, because even if the calcium level is low, if you give IV calcium, then what will happen is that more calcium phosphate will be deposited, because there's a lot of phosphate around that will combine with the calcium. If you can, then add a phosphate um, a phosphate buffer uh, to the management, and that is usually requires giving something orally that can absorb phosphate. This is what happens if you don't achieve a negative fluid balance. This was a child who had hyperhydration, and nobody was attuned to the fact that the urine outputs has to be maintained, and so instead of got a lot of fluid in and not much out, then where does it go? It goes on the lungs, and you get really wet lungs like this. You can see how this child's got quite severe pulmonary edema. So what goes in intravenously must come out in terms of the urine, and then you need to think about what the right doses of furosemide are, or whether to add some mannitol to achieve a good urine output. Um, Sometimes the amount of furosemide you have to give is larger than what we normally give, such as 0.5 milligrams per kilogram twice a day. You might need to give up to 1 milligram per kilogram every 6 hours, and that can be useful also in bringing the potassium level down if you've got hyperkalemia from tumor lysis syndrome as well. I wanted to discuss mediastinal mass because we've talked about hyperleukocytosis, we've talked about tumor lysis syndrome, and so let's talk about a mediastinal mass, another oncology emergency in children. And you can see in this X-ray that the mediastinum is widened, especially the upper mediastinum. And this is a child who had a T-cell lymphoma, and that typically arises, a T-cell lymphoma arises from the thymus, so that part of the anterior mediastinum, and that can enlarge so that it can put pressure on the airways, on the trachea or the bronchi. It can also obstruct the superior vena cava, and so patients may get superior vena cava syndrome with their face becomes quite plethoric, or they get periorbital edema, or they get edema of their face and neck. That's quite common. They often have tiredness on exertion or lying flat. They can't lie flat because when the tumor is in the anterior mediastinum, and if they're sitting up and leaning forward, then that takes the pressure off the airway and takes the pressure off the SVC. But if they lie flat, then that's falling back on the airway. The heavy tumor is falling back on the airway. So they often can't lie flat, and they often have to be sitting propped up on pillows. And they may have been doing that for some time, not preferring not to lie down flat, but sitting up. Oftentimes, patients who've got mediastinal masses also have pleural or pericardial effusions, and sometimes they're because of the inflammation around it. If a tumor has invaded the pericardium or the pleural cavity and it's producing lots of inflammation, it may be producing pleural or pericardial effusions, and sometimes their symptoms are associated with that, with respiratory distress associated with a pleural or a pericardial effusion, or they may have signs of tamponade related to that. The sorts of mediastinal masses that occur, well, firstly, in the anterior mediastinum, there are tumors of thymus origin, and they particularly are T-cell lymphomas or in T-cell acute lymphoblastic leukemia. In older children, thymomas they're not very common, they're quite rare, but they do occur, especially adolescent girls. Um, the thymus is very close to the superior vena cava, so it's quite easy for that to be obstructed if there's an enlarged thymus from a T-cell lymphoma or a thymoma. In the posterior mediastinum, that is the sympathetic ganglion, and in some young children, the neuroblastomas can arise in the sympathetic ganglion in the thorax. We get used to thinking of neuroblastomas always arising from the adrenal glands, but sometimes they can spread and involve the sympathetic ganglion. And then sometimes ganglioneuromas can occur. They're relatively benign, but they can occur in the posterior mediastinum as well, such as children who've got neurofibromatosis. They are more at risk of ganglioneuromas arising in the posterior mediastinum. And then some mediastinal masses will be sarcomas, not they're tumors of muscle or bone or connective tissue. So rhabdomyosarcomas or osteosarcomas or Ewing's sarcomas. or pleuropulmonary blastomas. They're all tumors arising from connective tissue. And then lastly is actually relatively more common teratomas, and they're germ cell tumors that can also arise in the thorax, and there are some clues to those things. This is a T cell ALL T cell lymphoma with acute lymphoblastic leukemia, the combination of the two, that occurred in a boy who was around about 10, and he'd had 3 weeks of respiratory distress and wheeze. He'd had wheeze, and he'd been treated by a doctor for wheeze with salbutamol, with Ventolin, and it wasn't getting better. He'd had persistent wheeze, and then he became so short of breath that he couldn't really lie flat without getting very short of breath. And then an X-ray was done, and this is what it showed. And you can see how enlarged his mediastinum is, and how big the tumor mass is, obstructing his airway, causing wheeze. There are 3 parts to the mediastinum. There's the anterior mediastinum, where the thymus is. There's a retrosternal airspace. There's the middle mediastinum that contains most of the aorta and the heart, and then there's the posterior mediastinum, and I should say the esophagus and the trachea. That esophagus posterior and the trachea anterior, and then there's the posterior mediastinum that contains the vertebral bodies, the sympathetic ganglion, and so different tumors can arise from these structures and cause mediastinal obstruction in various different ways. This is also a T cell lymphoma where there's enlargement. Hodgkin's disease can produce a similar appearance, usually involving the lymph nodes, the paratracheal and the para-aortic and paraesophageal lymph nodes. The image at the bottom shows this was a pleuropulmonary blastoma, which is it was a unilateral tumor that caused some obstruction to the left main bronchus, but not SVC obstruction. You can see the deviation of the trachea. You would look at this and say this child most likely has a pleural effusion, and the child did. She had a pleural effusion, but the basis for it was a mediastinal tumor, a pleuropulmonary blastoma. And this tumor on the larger X-ray shows, again, you might look at this and say, well, there's a whiteout of the left side of the chest. It could be a pleural effusion. It was a small pleural effusion in this case, but the majority of it, you can see, has what we call a variegated or a heterogeneous appearance. That is, there's some areas that are more translucent than others. There are some areas that are opaque. There's some areas that look like they're calcified. They're white, for example, those white areas. And this is a teratoma, where there's lots of different sorts of mesenchymal tissue causing a tumor enlargement. This was a child of 18 months who had a teratoma. It caused some obstruction. You can see the trachea being deviated to the right side, and there was some obstruction to the left main bronchus, causing unilateral wheeze. That's important. When you hear unilateral signs, then always get an X-ray just to see what's going on. So Hodgkin's disease or T cell lymphoma, a sarcoma of some sort, be it an osteosarcoma or a Ewing's tumor or a pleuropulmonary blastoma or a teratoma, can cause these sorts of tumors. And what they cause is not all mediastinal masses cause these obstructions, but sometimes they cause obstruction to the trachea, sometimes at the carina, which is the area where the trachea connects with the main bronchi, or sometimes it'll cause unilateral bronchial obstruction and lead to wheeze. So you can get stridor, you can get respiratory distress, bilateral wheeze, or unilateral wheeze. Just be alert to those things, especially if it's associated with facial edema. Like this young girl here has got superior vena cava syndrome with a mediastinal mass. This was a published study from India where the child had facial swelling, and the mother noticed first of all that the child's face was swollen, and sometimes the face becomes quite suffused and cyanosed. And as I said, sometimes they're associated with pericardial effusions because the mass is causing inflammation of the pericardium and leading to production of fluid. And sometimes they'll cause evidence of pulmonary artery obstruction. The pulmonary arteries are very close, obviously, to the aorta and the SVC, and they can get obstructed, and that can lead to hypoxemia. Sometimes there'll be ventricular dysfunction on echocardiography because of a pericardial effusion or because of involvement. And often if you do spirometry in these patients, get them to blow in a peak flow meter, sometimes it'll be very low. Any of these things, any of these features mean that the child's very high risk during sedation or anesthesia. And some of these children need they need some sedation, for example, to drain a pleural effusion or to drain a pericardial effusion, or they might need some sedation to do a lymph node biopsy, for example. And it's really important that we know just what's safe sedation in such patients. And the safest sedation is not no sedation at all, really. You should, when you assess a child with a possible mediastinal mass, then there's a few things to look for. And one is, if you do the oximetry, often the oximetry will be quite unusual. I'll just show you a picture of just video. You see how the oxygen saturation trace goes up and down, right? Constantly goes up. That's the arterial trace, but the oxygen saturation trace, I'll just show again. The oxygen saturation trace goes up and down with respiration, and that's the sign of pulsus paradoxus. And of course, that can occur when you've got any form of airway respiratory obstruction, or if you've got a pericardial effusion. But that's a good sign of something not right. And it suggests that there's alternating strong and weak beats depending on the level of intrathoracic pressure with each breath. You should check for SVC obstruction. There's a sign called Pemberton's sign, which you may know about. If you ask a child to elevate both their arms until they touch the side of their face, then a positive sign is that you get facial congestion or cyanosis or respiratory distress. And you can ask the child if they're comfortable lying flat. If the child's not comfortable lying flat, then leave the child sitting up or being propped up on pillows in a sitting position. That's very important because they may get obstruction if they lie flat. You can do a lateral chest X-ray to see if the mass is in the anterior mediastinum or in the posterior mediastinum, because that can help you understand what type of tumor it is. If it's in the anterior mediastinum, it's likely a T-cell lymphoma or a thymoma if it's an older child. And if it's in the posterior mediastinum, it's likely a ganglioneuroma or a neuroblastoma. It can give you an idea. You should get an urgent echo to make sure the cardiac function's okay and that there's no pericardial effusion. And you should do a full blood examination. If you can, a blood gas and electrolytes, measure the uric acid and the LDH, because they can be elevated in a tumor. And if the child can lay flat, then doing a CT scan, if you have access to that, can help you understand the type of tumor it is. Don't do a CT scan if the child can't lie flat, and don't do a CT scan with sedation, especially if you can't establish that the child can't lie flat. If a child's got a pericardial or pleural effusion, then it is important to drain that because often they'll get quite substantial symptomatic relief, and I usually drain that with just local anesthetic and at most very light sedation. Ideally, with the child sitting up, you should never give a neuromuscular blocking drug. I mean, this is anesthesia, but never give a neuromuscular blocking drug to such patients, and don't lie them flat, especially if they can't. You can get a lot of information from the pleural fluid or the pericardial fluid if you need to drain that. Hopefully the child gets a lot of symptomatic relief, but you can also test the pleural fluid for cytology and check to see if they've got leukemic cells in the pleural fluid, for example, and exclude that they've got an empyema by culturing the fluid. Usually, I've done some biopsies with patients sitting up, just supraclavicular lymph node biopsies, for example, or axillary lymph node biopsies. It's um, any more invasive biopsies are often very dangerous. So best to do the minimum possible and then start presumptive treatment. And that's why a clinical diagnosis of the type of mediastinal mass a child has is quite important. If they look like they've got a T-cell lymphoma or a T-cell acute lymphoblastic leukemia, then doing what I said with for initial therapy, hyperhydration, giving allopurinol because you know they're at risk of tumor lysis syndrome, giving steroids, and monitoring them for tumor lysis syndrome is what you really need to do. And then, of course, starting on cytotoxic chemotherapy. But again, today we're not talking so much about the details of the cancer management, but just how to deal with these emergencies. Let's talk about febrile neutropenia. It's a very common complication of cancer treatment, and it is an emergency. These patients have a risk of deteriorating very rapidly. Often after chemotherapy, the nadir, the lowest white cell count, is often 7 to 14 days after chemotherapy, and neutropenia is really defined as a neutrophil count less than 500 per millimeter cubed, or less than 1,000, but haven't yet reached the nadir. So if for example, a child's at 5 days and they're got a fever and their white cell count's 1,000, then you know that by a week, by 7 days, they're going to be much lower than that. And so febrile neutropenia, less than 500 or less than 1,000 per millimeter cubed, and fever, and that's an emergency. And those children require urgent treatment, so they should be categorized as a triage category 1. If they've got any signs of sepsis at all, then that's a true emergency. And ideally, you should try to get antibiotics administered within 60 minutes of all such children, and within 30 minutes if they have signs of sepsis. That's the sort of benchmark recommended, and that can halt deterioration of such patients. You should search for the source of the infection, and for children who've got febrile neutropenia, they can have infections in lots of different places, some the same as children who don't have cancer, but in some other places as well, and different sorts of infections. And so certainly in the chest, they can have pneumonia, they can have pneumocystis because they're immunocompromised, or they might just have a respiratory virus like any other child. They can have infections in their gastrointestinal tract and specific sorts of infections. They may have dental abscesses, especially if they're neutropenic and they've got poor dentition, then dental abscesses is quite common. They may, if they've got abdominal tenderness, and they've got neutropenia, they may have a neutropenic mucositis, and that can lead to tenderness, especially in the cecal area, so the right lower quadrant near the appendix. Also examine their perineum, because there's perineal infections are quite common. The perianal area, for ensure they haven't got anal fissures. If a child's got constipation and they've got neutropenia, then they may have anal fissures, and that can be a common site of infection. And if they've got diarrhea, then consider whether they've got mucositis or they've got Clostridium difficile. A variety of different sorts of infections can occur. They may have urine infections. They might have skin infections such as cellulitis, or bone and joint infections, or they might have central nervous system infections, or just generalized bacteremia. It can be especially complicated by generalized bacteremia, can be especially complicated if a child's got a longer term line in that they're getting chemotherapy, or they have an infected intravenous line from when they had chemotherapy. Many of these children don't have pus to drain. That's unlike children who don't have neutropenia, otherwise well children who'll often get collections of pus somewhere, and if you don't drain the pus, then you don't you won't get on top of the infection. Many children with neutropenia won't have pus because they don't have enough neutrophils to make pus, but it is important to still try to identify the source of the infection, and especially assess their IV cannula sites and just change the IV if it's a likely or a possible source of the infection. Very important to not leave them in. This is varicella zoster in a child with neutropenia. You've seen this sort of thing before, I'm sure. Not all children with zoster have immunodeficiency, but some can if they've got HIV or they've got neutropenia or some other form of immunodeficiency. And this is ecthyma gangrenosum, which is really, you'll see this quite a lot in children who've got immunodeficiency, either because of cancer treatment or because of malnutrition, for example, and they often start as what you might call septic spots, and then they can progress to they're usually embolic infections that occur in the skin, and it means that the child's got a bacteremia, often with Staph aureus or Pseudomonas, and the bacteremia is circulating in the blood and lodging in the skin and can cause this sort of necrotic breakdown of the skin. This is a very serious infection. And if you see septic spots like this, then, think of Pseudomonas or some other gram-negative or Staph aureus. This was Staph aureus in a child who had neutropenia, but you can see it with other infections, especially Pseudomonas. So our management of febrile neutropenia needs to cover all the likely bugs that can cause infections in such patients, and particularly Staph aureus. And the options are giving cloxacillin for methicillin-sensitive Staph aureus, and then there's a few options for MRSA as well, if that's common in your hospital or if it's more likely in a particular child. And they're using vancomycin. There's also another couple of antibiotics that will cover MRSA reasonably well. One is linezolid, which is a drug we keep usually for drug-resistant TB, but it's also a very good MRSA drug. And clindamycin, which is another drug that's highly effective against most MRSA Staph aureus, but not all. So secondly, that's Staph aureus, but you also need to cover Pseudomonas and E. coli and other gram-negatives. And ceftriaxone will do some of those, but it doesn't cover Pseudomonas. Ceftriaxone does not cover Pseudomonas, but ceftazidime does. It's the only difference between ceftriaxone and ceftazidime is that you get Pseudomonas cover. And mostly you don't need that in a community-acquired infection, but in a child who's got febrile neutropenia, then ceftazidime is more likely to cover that. And usually we use an aminoglycoside as well, such as gentamicin. So ceftazidime and gentamicin will give good gram-negative cover. They don't cover very well multi-resistant gram-negatives, like extended spectrum beta-lactamase producing gram-negatives. And for that, we need to use piperacillin tazobactam, or if it's a severe systemic infection, then using meropenem. If the child's got gut-related problems, for example, if they've got diarrhea, they've got typhlitis, they've got abdominal pain, abdominal distension, then you need to give metronidazole for managing gut pathology because they may have anaerobes. So I'm not suggesting you use all of these antibiotics. It's really you need to think about in a given child what are the most likely pathogens and using 2 or 3 of those antibiotics, no more than 3, but 2 or 3 of those to cover the child who's got febrile neutropenia if they're severely unwell. Right. I wanted to talk a bit about bleeding and coagulopathy, and there are some as another oncology emergency. This is the 5th oncology emergency, and again, bleeding is quite common in children who've got cancer, but there are some children with certain cancers where bleeding is more likely. And the first one is acute myeloid leukemia, and especially a type of myeloid leukemia called promyelocytic leukemia, where that problem I spoke of before, that consumptive coagulopathy is actually quite common, where you have a procoagulants, some inflammatory mediators that are going to cause the blood to clot more commonly, and that uses up all the clotting factors, and then the child bleeds. Um, that's quite common with AML. Other tumors, a stage 4 or advanced neuroblastoma is in children is sometimes associated with bleeding, but any leukemia or cancer, if a patient's got thrombocytopenia, either because of bone marrow involvement or post-chemotherapy depression of platelets, that can cause bleeding. And any child who's got sepsis and a cancer, or any child with malnutrition and a form of cancer, is likely to have vitamin K deficiency or vitamin C deficiency. And these two vitamins are very important to sort of think about if you're managing a child who's got malnutrition and any form of cancer, because they markedly increase the risk of bleeding. So the causes of coagulopathy and bleeding in cancer: firstly, the platelet count being low, and secondly, a consumptive coagulopathy. And again, these patients often they consume all their clotting factors, and so for example, their fibrinogen level will be very low. And that's important. If you don't have fibrinogen, then the other clotting factors can't work. So a child's INR will be high, their APTT will be very high, and their D-dimers will be very high. D-dimers are the fibrin split products. That means when there's consumption of coagulation factors, there's a lot of clotting, and then there's a lot of breakdown of the fibrin, the clot itself. But there's both excessive production of a clot and excessive breakdown of a clot. Then these things called D-dimers are released. They're just fibrin split products, and they will be increased. The key to it is looking, I think, at the fibrinogen and the INR. They tell you perhaps the most, and you should correct the cause if there's sepsis, etc. If there's a site of bleeding that can be managed in the usual sort of way, then treat that. You should give, for a child with a coagulopathy, then if they're bleeding, give fresh whole blood. Or if you're giving packed red blood cells, that's not enough to give packed red blood cells. You have to give fresh frozen plasma plus platelets as well. And ideally, FFP, platelets, and cryoprecipitate. The alternative is to give fresh whole blood, because that's got all the clotting factors in it. As long as it's fresh. If they're not fresh, then often the clotting factors are degraded somehow. Ideally, fresh whole blood, or for every unit of packed red cells you give, you need to give at least 1 unit of FFP, 1 unit of platelets, and ideally some cryoprecipitate. These patients should have vitamin K and vitamin C, especially if they're malnourished, but regardless, you should give them vitamin K, because they may not be making those clotting factors in their liver. The other thing about large transfusions or severe coagulopathy is patients who, if patients are hypocalcemic, if their calcium level is low, then their blood won't clot, regardless of how good their other clotting factors are. If they've got hypocalcemia, then their blood won't clot. And when if the ionized calcium is less than 1, then you could give them all the FFP and the platelets and everything you want, but it still won't clot. So you need to get their calcium into a normal range, not high, but in the normal range. And also, if you're giving blood to such patients and it's cold blood from the refrigerator in the laboratory, then that won't clot either when it gets into their system, because it's cold blood. So you need to try to warm the blood products to room temperature before you transfuse them. And usually, if we're giving large volume transfusions, then we'd use a blood warmer. It warms up fairly quickly in tropical environments when the blood comes out of the refrigerator. But don't give very cold blood to patients. I'm not suggesting you hang it for many hours to warm it up at all, but it shouldn't be given cold to patients, and you shouldn't allow patients to be hypocalcemic, which they will be if you give large volume transfusions. There's more to be said about the massive transfusion protocols that a hospital should have. We can talk about that another day, but I really just wanted to talk about the basics of 5 different pediatric oncology emergencies. That is hyperleukocytosis and the complications of that, tumor lysis syndrome, mediastinal mass, febrile neutropenia, and sepsis and coagulopathy. You'll see that they're all somehow interrelated, these conditions, but and there's, as I said at the start, there's more basic things that we need to understand about pediatric oncology, but these are the common pediatric oncology emergencies, and I hope that's been useful today. I'm going to stop sharing my screen now and happy to take any questions that you might have.